Thank you. It's a real pleasure to be here, and thank you for the invitation to participate today. And really fun to be here with my esteemed colleagues. The topic that we have is kind of a challenging one, but an easy one to research in the literature for sure. So I'm actually going to open up, first of all, just to get a show of hands. How many of you who participated in our workshop yesterday, the speech-language pathologists, are still in the room? Can you raise your hands? Okay, excellent. So yesterday we had a workshop addressing this very question, and our task at hand was to discuss sort of the background and the justification for why we might do speech treatment or voice therapy with individuals with spasmodic dysphonia and tremor. And throughout the course of the day, we also provided an opportunity to give some training and discussion to some of the methods that might be helpful. So now, of those of you participating who are not speech-language pathologists, let me see a show of hands of how many of you have seen somebody for voice therapy to treat your problem. Okay, quite a few of you. Now, of all of you who have sought voice therapy, how many of you found it beneficial? Okay, so that's actually a pretty fair number of you. How many of you who had voice therapy found that it didn't help you at all? Quite a few of you. And how many of you thought it was helpful, but it really needed to be supplemented with other treatment? Yeah, good. Okay, so that's not very surprising, actually. Now, you might notice I don't have a nice PowerPoint slideshow going on here, and so one of the thoughts that came to my mind was, I don't know if you saw the 2010 article in the newspaper. New York Times had the heading, "We have met the enemy and he is PowerPoint." That's my thought for the day. So, and this is really about you. So rather than, and also my talk is not going to have a lot of slides to it. So I decided to just make this more about an engagement between our experts here on the panel and with you in the audience. And just to give a little brief history about why has voice therapy become controversial. And I actually blame a couple of people, but I would say back in 1980 or so, we had a colleague who started to claim cures with voice therapy. And I think we all know this doesn't cure spasmodic dysphonia or vocal tremor, nor do our treatments that we offer you. They don't cure it. They offer you a way of managing your symptoms, right? And so everything we have to offer you is not a cure. As Dr. Ludlow referred to very wisely, we really haven't found the cause. And if we could find the cause, that might let us move a little more forward towards effective treatments. I don't know that we can cure, but that would be a great goal, wouldn't it? If we could find the cause and then come up with treatments that would address directly the cause. But what we have to offer you are methods that can help you manage your symptoms so that you can continue to participate in life. It's a very disabling problem. People lose jobs. People refrain from participating socially. You all have had your lives affected tremendously by this problem. And yet we want to participate in life. And our job as healthcare professionals is to get you back into life and give you ways of living your life fully and engaging with others and not being left out, that you can participate in those conversations freely. So we are not going to claim cures today. That's not our job. Our job is to talk about what is the role of speech treatment or voice therapy, and is it a useful tool? And if so, how would we go about managing problems? What are the experiences that we've had with those we've seen in our clinic? Now, of the workshop that we gave, which was advertised worldwide, we had 8 participants. And I want to go back to what Dr. Daly said earlier. The problem that you have is not one that many individuals in speech pathology feel very well equipped to treat. And they may not even know very well how to evaluate it. So there really aren't very many people in our profession, number one, who are voice experts, and number two, who have neurogenic voice experience to feel comfortable offering you effective evaluation and treatment. How many of you who've gotten voice therapy had to see several professionals before you got in the hands of somebody who felt comfortable working with you? Raise your hands. Okay, that's a surprisingly low number. I have a funny story to tell you. When I was at the University of Iowa and I was in my fledgling years, we started a clinic and had people coming in once a month for evaluations, and it was a voice evaluation clinic. And our receptionist got a pretty good ear so that she'd kind of listen to people and she'd know which clinic they were checking into. And a patient came in, and I happened to be in the therapy room just off our reception, and I could overhear this conversation. And the person came in and said, "I'm here for my voice evaluation." And the receptionist said, "Oh, you have spasmodic dysphonia, huh?" And the patient said, "I've been seen by 20 professionals over the last 20 years who don't know what I have, and a receptionist diagnosed me." And so that's just to illustrate that frequency of exposure, once somebody's heard it and knows you, they can identify you in a heartbeat when you walk in the room, and that really helps, doesn't it? When you find somebody who actually can help you and know what you have after seeing so many people who can't. So what I'd like to say is, when it comes to voice therapy, do we have any evidence that it's helpful to you? We have 2 publications in the literature to draw from, and each one kind of offsets each other. One of them did not control for one variable, where they asked patients to come back on a self-selected basis and combined Botox treatment with voice therapy. And the dependent variable that ended up predicting a difference that showed that voice therapy was helpful was that the patients ended up on average to get about 2 weeks more benefit than those who didn't get voice therapy with their Botox. Then a later study, very recently, in 2012, was published, and they actually controlled the interval of time between Botox and found no difference between whether you got voice therapy with your Botox treatment or not. But given that the earlier study found that the variable that made the biggest difference was the amount of benefit time you got between your Botox, I would say the jury's out. So the question comes up, and our challenge today is to say, as experts, do we think this is a good idea? What can we offer you? What are reasons for you to maybe seek out a clinician who can offer you some assistance with speech treatment or voice therapy? And I use those terms interchangeably because I think of them a little differently. First of all, your voice, I think of as the sound source itself and how it resonates. And the speech component is how we actually communicate. And we use our voice when we communicate and speak with each other, but speaking strategies may be a little different than some of our voicing strategies, and yet they go hand in hand. But it helps me focus as a clinician on what exactly I may do with you. So why might we want to do this? Why would we be involved in the picture at all as speech pathologists if we're not going to inject you with botulinum toxin? I would say that sometimes we're the ones who end up referring on to our counterparts in the medical profession to say, here's somebody who was referred with psychogenic problems and is manifesting in a voice problem. Curiosity, how many of you in the audience had somebody tell you that your voice problem was psychogenic, that it was all in your head? That's very common, and I often will have somebody with that diagnosis sent to me as the first line of approach on how to treat that problem. And in the course of talking with them and evaluating, I discover, no, I think this person has spasmodic dysphonia. So I might be the first person to actually consider that diagnosis. And then, of course, I want to have an otolaryngology colleague involved in that equation for developing the treatment plan. So we get involved a lot of times because of our partnership with otolaryngology and our role in doing voice therapy. And when it comes to the Botox treatments, a lot of times I'm helping my counterparts with the follow-up. I see the patients back and do the follow-up evaluation and check in with them on how well the Botox treatment worked. I do all of the voice recordings and the analysis and the evaluation. But I also am the person who can help deal with the communication-related issues that come up because we are therapists. So our job as speech-language pathologists, which is a name I don't really like personally, because I'm not dissecting you, is my job is really as a communication specialist. And so my job is to help you learn how to be an effective communicator and to deal with the problem that you have in a way that allows you to participate in communication activities. And so I'll be evaluating where the breakdown is, what are your challenges, what are your barriers, and trying to determine what the obstacles are even once you're having a Botox treatment, so that I can help address getting you back into participating in communication activities. As a job, I'm also educating and counseling you. A lot of times I find patients just really like to understand their problem, and I have the time to spend with my patients and educate them on what their problem is. Another problem that arises along with the neurologic problem are the things you do to compensate for it or adapt to it. And what keeps us in business is that when people have voice problems, they don't intuitively do things that are good. And so a lot of the strain and the effortful levels that you use to try to overcome the problem that you have are exactly opposite of what you want to do. So another role that we play is to do voice therapy to address what we call muscle tension dysphonia, or some of the more hyperactive muscle activations you do to strain or to put effort forth to overcome your neurologic problem. There are some ways that you can try to talk and not use as much effort, which will, with that increased effort, will increase the symptoms that you have or worsen them. So we can provide you with compensation or compensatory strategies, help you modify how you're talking, give you strategies that you can call on as the Botox is wearing off. And no, it may not affect the length of your benefit in some cases, or it may not cure the problem, but it might give you a tool you can call out of your back pocket when you need to help you continue participating in your communication activities. So that's really our role as I see it. So our job today is really to address this particular topic, and we have some excellent experts on our panel today who've all had experience working with individuals with spasmodic dysphonia. I've also been interested more recently in individuals who have vocal tremor, and developed a method that I like to use to modify how people with vocal tremor speak to help lessen the perception of that tremor in speaking. And nothing that we do is going to be fun or easy, and it's just like physical therapy, which I'm enjoying right now, where they ask you to do exercises and you have to do them on your own, and you have to learn how to do them independent of the therapist, and they make you work and think about what you're doing. And when you talk, since we do that frequently, probably more frequently than I have to do my physical therapy, our job is also to have you think about strategies you're learning in our sessions every time you talk. So that's how I see our role, is to help give you strategies, be supportive, and everybody has a little different approach with their patients. So I'm going to ask each of the panelists at this point to introduce themselves, and I'd like you each to make a statement about a pro and a con of your role as a therapist doing voice therapy or speech treatment with individuals with spasmodic dysphonia or spasmodic dysphonia and vocal tremor. And let's go ahead and start with Kate DeVore.
Hello. This is why we couldn't hear Dr. Daly. I don't think this one's working. Can you hear me in the back? Yeah? No, you can't. Okay, great. Thank you. Okay, there we go. Hi. Much better. I'm Kate DeVore. I am a speech pathologist and a theater voice coach and a personal development coach. I'm here in Chicago. You're going to be seeing some more of me later this afternoon. And for those of you that were here yesterday, Dr. Barkmeier and I led that workshop for the speech pathologists here yesterday. A pro and a, wait, so you want what now? A pro and a con?
Pro and a con.
Okay. A pro is, I believe wholeheartedly that the major benefit that I bring to people with spasmodic dysphonia is indeed, as she was saying, to help release the extra tension that comes in as a compensatory issue. So I see people feel more ease, and I see people come into more balance with various stages at various points in the Botox cycle. And so I think that's the biggest pro, is that it can really help with ease, and it can help with the compensatory things that come into play. The biggest con, I would say, is when I encounter people who choose not to have Botox, and it's frustrating because there's a limit to how much benefit they can get. And there's still some benefit, as I was talking about with the tension, but that can be challenging, I'd say.
Mm-hmm. And Jan Potter-Reed.
Let's see if mine works. Yeah, it does. I'm Jan Reed. I work at University of Illinois Medical Center, Chicago Institute for Voice Care. My philosophy in approaching therapy, I'll twist it a little bit, if you don't mind.
You're going to do your own thing after you are given explicit instructions?
Yeah, no, I'm going to.
That's so unlike you.
I know. I'm still going to do pros and cons. I am. I see the. Oh, I'll do the con first. I think the con in our involvement with the spasmodic dysphonia community at this point is the lack of protocol, the lack of research, the lack of evidence base, which we all as professionals hang on to, that we say, oh, we can cite this study, that was successful, that wasn't. So from a clinician standpoint, it takes a little creativity on our part to use methods that we know work with other disorders. And I'm segueing into the pro now, where we know aerodynamics, we know how the phonation tube works, we know how the articulators affect the voice and how it can stop and start and perturb the signal. And we can take that with enough creativity and enough information from you all when you come in and help you manage your day-to-day communication, as Julie said. So even though we may not have the research right now, and we will in 5 to 7 years, yeah. But
It's a private joke from our workshop yesterday, sorry.
In the meantime, I wouldn't stay away from voice therapy as an augmentation to your medical treatment, because we can offer you a lot of strategies, and but you're going to have to tease out one of us who has this curiosity and this willingness to tweak. Is that fair? Yeah. Okay.
Mm-hmm.
All right. So that's my.
Excellent. Thank you. And Dr. Julia Edgar.
Now, do I have to come up with something that's unique now that I'm the third one on the list?
And I know you will.
I am Dr. Julia Edgar. I have a faculty position at a small liberal arts public university in Missouri. Historically, I've been at other university sites, but I've also have a lot of clinical experience. And I did, like Dr. Barkmeier, do a postdoctoral study with Dr. Christy Ludlow. So most of what I know about spasmodic dysphonia started in her lab. And in terms of the pros and cons of therapy, and I tend to be a rule follower, so I'll address the questions as asked. I find one of the cons of the therapy being that when the patients come to me, they are, I think, just really hopeful, and we cling to those things that we want, whether there's evidence to support what we want or not, but they want the therapy to take care of the problem. And so then there's that kind of discussion of, no, just stick with this a little while. It can still help the problem, but it won't cure the problem. And so just having that discussion with the patients who are so in desperate need of a full resolution of the problem. And then the pro of therapy being that by, similar to what Kate and Jan have said, is taking what we know about optimal voice production. And I really like to look at how the person with spasmodic dysphonia is producing voice aside from the spasms interfering. Because if you listen to the world of speakers around you, you hear many who use really good voice quality, and you hear a lot of people who use not good voice quality. And so you may have been someone who was somewhere not on that optimal quality and before you started having your symptoms, and so you have an overlay that's not optimal. And even those of us who I like to think I use optimal vocal quality, I don't do it 100% of the time. And so how do you tease out what's the disorder and what's not, what may have been there before the disorder manifests, as well as the compensatory things. And I think the therapy can really help with that. And that's one of the challenges of that treatment that I really enjoy helping to tease out.
Excellent, and I think that was beautiful voice quality. I have one more question before we go into the questions from the audience. I'd like each of you to pick what you think has been one of your, every clinician, I believe, has a favorite method that they like to use. And as I mentioned yesterday in our workshop, one of our esteemed colleagues, Kitty Bertolini, was one time heard to utter, "I just think it all works. It's just, everybody should just pick what they do best." And yet, I think we all have to consider what's going on in a person's voice problem. And for spasmodic dysphonia of the adductor type, the abductor type, and when tremor is also a part of the problem, we have to think about the mechanism and what's going on, and it might make us use one technique over another. So I'm going to ask each of you to consider what you think is one of the best methods you've used when you work with a patient with spasmodic dysphonia, and share that approach. And we'll start with Kate again.
Okay. I mostly use resonance-based voice therapy techniques. So this involves a combination of exercises to help release extra tension from the system, which includes the neck, the larynx, the shoulders, the breath system as well, and connecting to the breath, because of course spasmodic dysphonia disrupts the relationship between the breath and voicing. That's one of the biggest problems. So helping connect there, and then finding a placement or resonance that creates a vocal fold configuration that gives you the most acoustic output for the least wear and tear on the system. And there are particular resonance-based exercises that create this balanced phonatory style and this ease of muscle use. And so that's the combination that I like to use. And of course, I'm sorry, everybody is so different, right? So that doesn't look the same with every person. That might be the same principle, but that's one of the other challenges. I thought, of course, as soon as you asked about pros and cons, and as soon as I put the mic down, I was like, oh, there's another one. And one of the cons is how different everybody presents and how many variations there are. And a lot of that has to do with what Dr. Edgar was saying about how a lot of it is about how you were before onset. And so we all don't speak the same way, so.
I think you may hear a consensus of opinion between the three of us here in basic approaches. I also go with the resonant voice approaches, starting with breathing management. I do a lot of body work. I may have my patients down on the floor, opening up the chest, using some yogic techniques. I have many things in my bag of tricks, and again, individual approach. Depending on where you're tight, I do some myofascial release. I might do some manual manipulation if it helps just get you a feeling of success when you're with me in the room. And once you feel that success, then we take that as a springboard and figure out ways during your day. And sometimes I ask personal questions about exactly what do you do every day and how can we do this then, and using the motor learning principles to wire this into your brain by multitasking your practice at home. So you're doing frequent, short, correct practice in a natural situation. And my folks are managing their SD pretty darn well. Not 100%. You always get tired. You always get stressed. But it's and it's a moving target. So I would say the resonant voice. Occasionally, I'll do a little flow phonation. For AB, that's a little trickier, a lot more individual, a little more airflow based. So there really isn't a named technique for that. So yeah, that's my general. Julia.
I start with respiration. So I start with breathing, and I really study how the individual in front of me is using their breathing mechanism. And so are they primarily moving their chest when they breathe? Are they nice, low, relaxed belly breathers? Is there a fight in the body between one part of the body and the other in terms of the breathing? So I start there, and then I move into resonance. So, I think you're right. We're all kind of picking on the two main things, but maybe where we start, where we focus, may be just a little bit different. And of course, as the others have said, it is very individualized. But I do tend to focus a little more on the breathing long before I move into resonance.
Excellent. I've been asked to also just let everybody know that this afternoon there will be opportunities for you to meet with speech pathologists. I think Kate DeVore and I are designated to work with individuals who are interested in speech therapy techniques. So at 1 p.m., the topic will be vocal tremor. At 2 p.m. is abductor spasmodic dysphonia, and at 3 p.m. is adductor spasmodic dysphonia. So if you want some firsthand engagement with us this afternoon, and I know Kate is also doing something at 1:15 that maybe you could mention a little bit more about what that will be as well, as sort of a precursor of what's to come. Do you want to just share what you're doing
Sure,
at
thanks.
1:15?
It's, I think it's called Mindfulness, Meditation, and Progressive Relaxation. And it is not a didactic talk. It's not a lecture. There's no slides. It is, I'm going to talk for 5 minutes about why it's useful, and then I'm going to take you through a progressive relaxation exercise and a meditation exercise. So it's just for you to experience some mind-body stress reduction techniques.
Okay, thank you. Jan, I have a question for you. What is being done to dispel the notion in the SLP community that voice therapy is a waste of time?
You set that up, didn't you?
No?
Oh, all right. Nothing officially. I mean, that's a fair statement, I think. Nothing officially. I think the best answer to that question is...
Thank you.
You can tell I'm not a theater person, can't you? I'm not microphone savvy. Anyway, I think your best approach to that is to find one of us who knows SD, who has some experience with SD, who works with a laryngologist who knows SD, and to be open to the process. And just, we don't know as professionals. We don't have a protocol, as I said. We don't know the answers. So we're going to work with you. We're going to take what our basic knowledge, and we're going to go through the process with you. This is kind of brand new, because for a long time we've been told as part of our education, SD is mentioned as a neurogenic voice disorder, and we're told in graduate school, can't do anything for it. So it's a pretty rare SLP, especially the newer generation, who are tackling this, who have the knowledge and the willingness to combine things. So I think it would involve a willingness on your part as a patient to be part of our growth professionally. Does that make sense? Okay. Yeah.
Since Jan mentioned that in graduate school we're often told that we can't do anything about it, I want to say that as an academic professor, that is not my tactic at all.
Mm-hmm.
Now, I'm a newer generation clinicians will hopefully have more information, it's very side specific even. And so I spend as much time as I can fit into a limited curriculum that to talk about the signs, the symptoms, the difficulties in diagnosis and what the patients go through, and that it is our mission, even if you are a school speech-language pathologist and you come across a patient or a grandparent, a parent or a grandparent of one of your clients on your caseload, or if you're out in your church or wherever, even if they're not people who come to you on your caseload, that I want you to know these symptoms. And even if it's 5 years out and you haven't heard it yet, if you hear something that sounds like an abductor break, that you can wait a minute, I heard this because I play as many samples as I can in class. And I don't have a lot of time to talk about the treatment, but I do tell them my personal viewpoint on that. And so hopefully, I think even as the coalition study is going forward, I think Christy, at least early on, part of the goal for that was to have training protocols so that the graduate students will have the ability to make those diagnoses and then tie it into the treatment as time goes by. So hopefully that will be evolving sooner than later.
And I want to add one other thing too. This may be the only question, who knows? But one of the valuable tools that we have as clinicians is part of our armamentarium in evaluation. It's called the Consensus Auditory Perceptual Evaluation of Voice, the CAPE-V. And Dr. Barkmeier-Kramer was one of the co-authors, were you not, on that? And there are 6 sentences total.
That's
and
correct.
when I've supervised and trained graduate students, they always want to know, well, what, they want the bare minimum voice evaluation, and so I tell them, just memorize these 2 sentences. We eat eels every day, and the puppy bit the tape. Right? So we can get a lot of information on whether SD is present or not with those 2 sentences. And then take it from there once the patient comes in. But,
Or they could do the differential diagnosis protocol that Dr. Ludlow and colleagues put together.
they could do that, but they don't want something
a
that
little more
lengthy, yeah.
Yeah. Yeah, you're talking about, and that would be great if we could develop a screen that doesn't take an inordinate amount of
Right,
time.
right.
People are always worried about time these days. There was a nice song from Chicago they should listen to. Since we're in Chicago, the group Chicago. A question for Kate DeVore. I'm going to revise this question. I apologize to who wrote it, but I think what you really want to ask is, can you describe the proper breathing technique to relax?
Well, I'm going to pull a Dr. Ludlow and say I'm going to talk more about that this afternoon. But if you don't want to come to that session, I will answer briefly now as well. The most important thing is that you're breathing low rather than high, generally speaking, because when we breathe up here, can you see me? I'm pointing to my collarbone area. So when we breathe up in the collarbone region, we have to use what are called accessory muscles of respiration, which are these little muscles around the neck and the top of the shoulders. And when we do that, it creates a lot more tension in the neck and shoulders because you're having to lift your entire thorax, your entire rib cage, and all the flesh that's on it in order to make room for your lungs to expand what turns out to be a very small amount. More of the lung expansion happens in a downward direction. So learning how to breathe abdominally so that when you inhale, your belly moves out, and when you exhale, your belly moves in toward your spine is the shortest answer to that question. Is that adequate, would you say?
I think that's great. Yeah, and again, more on that this afternoon.
Yes, we'll be doing it this afternoon. You'll get to feel it.
Now, this is a question for the whole panel, and I'll start this time with Dr. Edgar. This is really an excellent one, and I'm going to combine it a bit because it's really asking how can you, as the patients, help in a couple of ways. The first of these is please comment on how our esteemed audience can play a role in educating the future speech-language pathologists about their problem and contribute to the educational curriculum in some capacity. What would you advise them as far as ways they could contribute in that way?
Well, this is actually something that Teresa Dunn in the back there and I have discussed. We help lead a support group in St. Louis. And one of the things that we've talked about, we have yet to implement it, is that if you would be willing in some of the support group meetings you have to invite some of the graduate students from the local universities to come and have one of the meetings set up so that it is actually educational for the students. Like I said, we have yet to do this, but if any, there are universities spread far and wide with speech pathology graduate programs or undergraduate programs, even if they don't have a graduate degree. And I did this once with a different patient population. I did this once with a laryngectomy support group. And we set up the whole meeting. And so the students came, and I prepared them with questions so that we actually had a panel like this. And that we had a panel of the laryngectomy patients, and the students had prepared questions in advance so that they could thoughtfully, go through their notes and think about, well, what do we want to know? And it was so helpful to them to actually see, meet, greet the people who had the disorder that they were trying to learn about. And it was so much more real for them. And so I think that that's one thing that if you do have an active support group, that if you make a link with the any nearby university to see if there isn't a way that you can tie in that kind of activity.
Mhm. Thank you. Jan?
I agree with everything you said. I think that's a great idea. And I think just overall out in the community being, obviously an advocate with your physician, your primary care physician, as Dr. Daly, you talked about that, yeah. But the students are the key, because they're the next generation. And I think that's a great answer.
Okay.
I wouldn't add to that.
Nothing to add. Okay. I apologize for my throat clearing. I haven't yet had my coffee today.
And that's my fault.
I'm good at teasing Jan. We'll start with you, Kate. What are some ways that you can think of that we could also encourage more research or treatment studies being done without the combined modality approach, so we could actually parse out whether, if, and how any of the speech therapy methods currently available may be beneficial to this population?
Well, that's an interesting challenge because it would involve withholding Botox, right? And so that's a questionable thing, right? I guess maybe if you just did it for like 8 weeks, it wouldn't be that big a deal. If you're like, okay, you've waited this long, wait another 8 weeks and just do therapy, and then we can add the Botox in, perhaps. But that's the first thing that comes to mind, is the challenge is that it involves that. So I would treat it as any other voice therapy protocol and get control groups and have some with voice therapy, some without therapy, and different therapy techniques perhaps, using some of the flow phonation, some of the resonant phonation, and definitely I would rate it on not only audio perceptual changes, but also patient perception, quality of life changes, and improvement after therapy.
Mm-hmm. And Jan or Dr. Edgar, would you like to comment as well?
There was a study done at Washington University in St. Louis looking at the benefit of Botox over time, and they injected the Botox, and then they made patient phone calls like every 2 weeks, and were checking on how they did. And what they found there was kind of a peak time of when the treatment was really effective. And so if you could do something like that, actually, I think, and combine the treatment with the Botox, but take those measurements, say, for a cycle first without the treatment, and kind of as a Botox baseline of, and of course, it did change a little bit cycle to cycle, as I'm sure you all know. Sometimes your injection is just, gives you a fantastic result. Maybe the next one is an okay result. So it wouldn't be perfect. But then if you added the voice treatment with that, and then again measured every time to see, maybe it's not going to change the duration between the Botox injections, but would it perhaps enhance that period of optimal voice in the middle?
Mm-hmm.
That would be one possibility.
One other. What I often do clinically, which I think could be done in a research paradigm also, is I will have someone come to me with a question mark dystonia. We don't know yet. They haven't been scoped. They don't know exactly what's going on. They have a scope. It's maybe not horribly obvious that it's a spasmodic dysphonia or a tremor or whatever. But what we do know is they have a horrific muscle tension dysphonia that has developed to compensate for the voice disorder. So what I will do many times is say to the patient, let's work on that muscle tension dysphonia. Let's get underneath that and see what we're left with. And in many, and I think from a research standpoint, the approaching the muscle tension dysphonia, then with patient satisfaction scores, maybe some numerical measurements, maybe that's good enough for many people, and the medical treatment wouldn't be needed. Or as the SD evolves, as we know it does sometimes, then maybe the medical treatment would come in later. So I think there's some value to our contribution in the research world that way too. So.
Okay.
Okay.
Dr. Edgar, on that note, so if we're proposing speech therapy, how do we get insurance coverage to cover it?
Remember, I'm in an academic setting.
Yes, but I know where you were before there.
That's a really good question, and I don't have a great answer for that. The times that I have been involved in providing treatment for a person with spasmodic dysphonia, it hasn't been a big issue, but honestly, it's been several years since I've been in a situation to try to bill insurance. And so, and I know that it gets more and more challenging all the time for those services.
Yeah.
So I think the justification may be just trying to look at viable work days, to kind of base it on the person's income, and that this is really interfering with their work, and that the therapy may help with more work days and fewer lost work days.
It sounds like both Jan and Kate have comments to add.
Okay, we'll just go this way. Actually, clinically, I've had some experience with, very recent experience with that. There are a couple of insurance companies who are notorious for not liking to cover voice therapy for anything. However, Aetna being one of them, Aetna's probably the worst, and some of the Blue Cross policies would come up a close second. But interestingly, with those companies, I think because the physicians have done such an excellent job of having a nice medical description for SD, there's a constellation of symptoms, there's, the phenomenology that Dr. Bastian talked about. SD appears on the list of covered disorders for therapy. And so then it's incumbent on us, when we write our reports, to talk about the medically necessary benefit of therapy, which the way I look at it is, you can't just say quality of life, because insurance companies don't care about that. But again, I ask these personal questions in my clinical interviews. You may have little kids, and it's really important that your voice be at its best as much as possible in case they're sick and you need to take them to the ER and you need to communicate with the ER doc on what's wrong with your kid. So, it's a health and safety issue at that point. Or you have an elderly parent, same thing. Many times you have elderly relatives who they're hard of hearing and you need to talk loud, which, as you know, with AD, you can't talk loud very well with that. So I will get real specific sometimes on my medical need statement for, an occupation certainly is an issue with insurance companies, because many of the health insurance companies also then segue into the short-term disability coverage. And they sure don't want to pay for short-term disability. So we will talk about, I use the words restoration, functional restoration. There's certain phrases that get an insurance company's attention, and they like that. And I mean, we're not doing anything unethical, we're not lying, we're not tweaking the truth. I mean, it's absolutely true. It's just the way we phrase it in our reports.
I think MTD is often covered, and since that's very often concomitant, maybe we bill that way and go in the back door.
Yeah, that's good. That's very straightforward and to the point. We have time for one more question, and I'm actually going to direct this one back to Kate. Yesterday, we talked a lot as a group that there are many of you with spasmodic dysphonia that are not very interested in Botox. So we certainly have seen our fair share of patients who come to us and they just really don't want to pursue the only medically based approach that seems beneficial, aside from surgery is another option, but that there are certainly those of you who are not interested in the medical management approach and insist on voice therapy, and that's actually how I developed my vocal tremor approach, was I was forced into it by a patient who forced me to do it. So you are very influential. Kate, can you speak to any patients who have improved so much with voice therapy that they were able to discontinue Botox, or speak to those who didn't want Botox who you treated and address your experience with voice therapy in that context?
Yeah, and I just talked about this yesterday, which is why you're asking me, I know. The first one, no. I have never worked with anybody who then discontinued Botox. So that one, nope. But I have had several people who came, and there was a woman who came from New Zealand because she had read my book and she wanted to work with me, and she actually made a point of saying, I don't want you to tell me even if it is spasmodic dysphonia. I'm sure it is. I don't want to know because I don't want Botox. I'm just not going to do it, and so I'd rather not even know, and I want you to help me work with what I've got. And we did. And so she was able to it certainly didn't stop the spasms. It didn't stop them. But it gave, what the therapy we did, she worked with me for like a week, and what the therapy did was give her enough tools that she was able to get through her day much more easily. And so she was able to reduce her effort. She was able to reduce a lot of the tension that contributed to this strangly feel that she was feeling, and parse out what is the spasm and then what is your body's reaction to the spasm. Because once that happens, we have a response to it very often. And so she was able to separate them, and so then the spasms were just the spasms, and they were ultimately less severe than the combination of the spasms and the compensatory tension that went along with them.
Excellent. So in closing for our panel discussion, I have two closing comments that, well, one comes from a question and a comment from the audience. Is it true that 97% of speech pathologists are women? And if so, how did I get stuck with Mike and Rick? That is absolutely my favorite question, whoever wrote that, and the answer is yes, you're right, and dumb luck. And then the final closing comment was, with voice therapy, I found it helped me manage my voice better, build my confidence, and alleviate some fears, so keep on. And I want to say thank you for that comment, because that is the role we hope we play. And with that, I want to thank my panelists for a wonderful discussion. Thank you for your questions and participation. And please, I encourage you to keep engaging with your healthcare professionals, both to educate, to influence, and find your voice. Make your voice heard. Thank you very much.